precious, just like mine. My face needs a bed really soon. My sinuses, I've got bad sinusitis and it's all nerve pain this way on the right side. So I'm ready to take some Tylenol, which will knock me out and put my head down a little bit.
Yeah, get some good rest.
Yeah, plenty of fluids, keep it, moist.
Flushing.
So,
yeah.
Yeah, oh my goodness, yes. All right, people are here. It's going to be the recording. Remember, you're going to get all of the professors' recordings. I suggest you listen to more than one. There's only 3 of us. I would listen to all of them. We all describe things differently, and maybe what I describe and somebody else's add on works, or maybe you didn't get what I said, etc. So all I can do is help. I can tell you those students who ended up with a 99.99 on the HESI went to every single review, and there was 5 professors at the time. And that's how they did it, by that repetition. So that's my encouragement to you. So next week, we're going to have our first exam. Our first exam is week 4. It'll be during your class time. Any questions with that, get to your professor. If I'm your professor, just let me know. So general questions, pediatric review. I'm going to give you some questions, give you some answers, and some I'm just going to give you some information. So Erik Erikson's first 5 stages of development. Now, I think you already can see by your first quiz that you're going to see this stuff. I can warn you that you're going to see it on your NCLEX in the end. And I know the HESI had 4 questions. So this is, and I know the exam, of course, has it. So this is something you need to understand. So I think that we could start by saying trust versus mistrust. These are your infants. That means all their needs are being met. They know they cry. They know somebody's going to take care of them and give them what they need. Autonomy versus doubt is now your toddlers. And now you're starting the me, mine, no. And they start to understand what they can do. 3 to 5, again, it's understanding that they can do so many things. And if they want something, they can go get it. They know how to do it. Let me turn that off. Gotcha. Industry versus inferiority, school age. Industry means they can do something, do it well, and seek the praise from it. They love to be able to, let's say they are the spelling bee champions. They love to have people praising them for it. That is your industry, whether the task is sports, cooking, playing an instrument, spelling, math. That's the industry, that's the task. And then inferiority is when they cannot do something as well as somebody else because they want to do everything well to get that praise. And then we talk about that adolescent, and it's that identity versus confusion. Think about teenagers at that peak in life where they're going from being in parents and doing what parents say to going out on their own. So who am I? Do I like girls? Do I like boys? What do I want to be when I grow up? What peer group am I going to join? They need to have the identity with their peers, and they're confused because they don't know exactly what they want yet. So those are your Eriksons. Freud. Freud talks about sexual things and oral things. We know that Freud, you might get confused with Freud in the early stages, infant stage, because we have Piaget, which talks about sensor-oromotor. That means touching mouth and moving it around, okay? Textures, etc. But Freud's all about mouth. They explore the environment through their mouth, biting, sucking, chewing, everything in their mouth, okay? Then it goes up to the anal stage where they're trying to go poopy in the potty. Phallic stage, when moms are more connected to their sons and the daughters are more connected to the fathers. It's just what it is. Latency is your same-sex peers. This is part of that heterosexual same-sex peers. Getting those praise from those peers is what they want. And then the genital stage is where you go into your adolescence. And this is now where they're interested in those opposite sex peers. When you think of Kohlberg, I want you to think about a child who knows right, who knows wrong, and knows that there is a consequence for either doing something right, which is a good consequence, or a bad. And that is basically your younger ages, your 3 to 7. So good and bad, and there's a consequence, a good one or a bad one. Then it goes up to the point of conventional level. Children become concerned with being loyal and conform. They want to do things well and be praised for it. They want to do what they're supposed to do. And then post-conventional is where they try to do what society says. It's like, what the Joneses do. The next door neighbors will be watching you. It means you're doing what you're supposed to do, so you're getting nothing back. They don't want to have bad praise back. This is all part of the same thing, and moral, and what it goes over is just, the Milo's hierarchy going into that, and basically what I said. Now, play. Those in my class know I talk about play all the time, and it's so important. And there are many different sorts of play. And we know play is what sparks a child's imagination. It's a way that they work with other children together as a group, and that these children, when they work together, sometimes they're for a goal, whatever that goal is. So these sort of plays, what are they? Well, onlookers, you're watching a child. The one kid's watching another kid, and they're just seeing what's happening there because they're trying to say, what are you doing there? And trying to understand. So it's imaginative for them. Solitary play, kids all by themselves. And they want to just build their own block tower. They don't want to be bothered. They're by themselves. Parallel play, you might be playing with the same toys next to each other, but you're not interested in the other person. Associative play is when they are playing with the blocks together, but they're talking now, but they're not trying to do it together to reach a goal, to create something, to make a house. Now, cooperative play is when you put children together. They work on the same thing because they want to make something, whether it is a castle in the sand, whether it is a house of blocks. There is a goal at the end of cooperative play. So what are the functions of play in a child's world? Well, we know play is important, and it creates that imaginative brain and makes them get to the point of conceptual thinking and putting things together. And it really increases the cognitive development of a child. So play allows children to use their creativity, and then they learn how to move things using different hands, and then, building blocks and figuring out how those things done. And this is really important for the brain, for cognition, and it helps a child grow and to learn and understand what's going on around them. Oh, that kid has something new. Let me play with that. Let me figure that out. And it's always sparking that imagination. Now, in pediatrics, we're always going to use play. We have our play therapists that are the best thing since sliced bread. These are people who come in who play with children and get paid for it. So it's a great field. But therapeutic play is when you have a child who needs to have whether hospitalization or procedures done, and that they can show them what's going on. They can touch, feel, and see things, whether it's starting an IV, whether it is feeling that tube. You can demonstrate this therapeutic play on a doll, and they could see this is where it's going to touch. And what does that do for a child? Well, it makes them understand what's coming next. So it gives them more confidence and security. As I said, child life specialists, most are masters and doctorate prepared. And they go into the hospital. And as I worked in an emergency room, they were the best thing. They helped you prepare a child to be relaxed and have decreased stress when you needed to do procedures. Now, taking an allergy history can be confusing. Children do get allergies and some more severe than in other. So it's important to ask quite a few questions when we're working with that. So we need to know, have you ever had a reaction to anything, any drugs, anything at all in the past? And what happened? Describe it. Was it a rash? Was it, stomach pains? Was it anaphylaxis? And how did you, was it rubbed on? Was it drinking? Or was it an injection of something that you were taking? So how is it taken? And then how quickly did it happen? Some medications, you get reactions quickly, and some take a little bit of time before you feel that reaction. Um, when did the kid have this reaction? The kid's 5 years old. Did he have it when he was 6 months old or when they were 5? Knowing when that happened. And did a doctor, did a nurse tell you that that was an allergic reaction? It could be an intolerance versus a reaction, and there is a difference there. Finding out, did you try to take that medication again? Did you do, like, say doctors say, well, it was an intolerance, not really a reaction, let's try again. And then did a reaction occur and what happened? So do you tell the doctors and nurses about this reaction every time asked? And this is something that every nurse will tell their parent and children. If you've ever had a reaction to a medication, make sure, do you have any allergies, that you answer yes and know the name of the medication. Cultural differences when doing a history. There is ways of talking to many different cultures. Some of them you can't just go in and start talking to them, looking them in the eye and touching them, and that's against their, cultural beliefs. So how do you work with a culture you don't know? Let's say it's a Buddhist family, or someone's dressed in different garb that you don't know what it is. Well, for you to understand culture, you need to ask questions. So say, what can I do to help you? Are there any things, preferences? Are there food discussions, or is it a caregiver? There are cultures who do not want a male taking care of a female, and conversely. Some cultures do not like taking their dress, and their clothes off. Most of them have the scarves and the hats and the robes, and they don't want to. So only disrobing that area that you do need and being cognizant of that fact, it will help you have a better relationship with them. And again, you don't know something about anything with a child, I don't care if it's adult either, but especially with a child, ask questions. A parent or a child will be very appreciative. So what do you chart on the electronic health record after your pediatric assessment is complete? Well, when you're doing physical findings, and this is physical. So when you're charting physical, that means stuff you can touch, you can hear, you can listen, you can smell. This is something that's physical. Vital signs, something that you do, is part of a physical finding. Growth, height, weight, head circumference, abdominal circumference, chest circumference. These are all physical findings. And then what were the breath sounds? What was the abdominal sounds? What were the pulses? All of these things are part of a physical finding in an electronic health record. Now, what is the most important influence on growth at any age? And the answer is nutrition, nutrition, nutrition. Children, especially infants, we know that group goes from 7 pounds to 21 pounds in the first year of life. That means they triple their weight in the first year. They need a healthy diet to promote healthy growth and development. They've gone from not being able to lift their head up to be able to run away from you. So they need that good nutrition. They double their weight at 6 months and they triple it at 1 year. So how do they do that? With nutrition. Why is it so important to do frequent developmental assessments throughout childhood? Well, we're going to be doing heights and weights because we want to see, is the child behind, or do they weigh too much? Are they prone to obesity? Or do we know that this child at 9 months old can't lift its head up? There's a problem. So when we find these, we do these developmental assessments, we can diagnose these deficiencies and institute early intervention quickly. I mean, if it's part of school, we can get special help for them. And that sometimes maybe it's things like, dyslexia. This is part of developmental, being able to read, and not transverse letters. And again, all the reasons why we do it is to find deficiencies so we can institute early interventions, physical therapy, occupational therapy, speech therapy. So what are the steps of doing an abdominal assessment on a child? Well, in a child, when you're doing an assessment, the first thing you're going to do is look. You can see color, you can see the way they're breathing, are they alert, their movement, we can see, nasals flaring, retractions, we can see them crying. So first thing we do is look, and we can see that easily. Once we do that, we're going to take our stethoscope and start listening this is to an abdomen. So we do all of the quadrants very slowly. Then we'll do percussion, same thing, and it's because we're going to look for fluids, a mass, something. You're going to find out as we go forward into the GU system, there is this big tumor that's in either the right or left lower quadrant called a Wilms tumor. That's something we find only doing an abdominal assessment. Sometimes children don't even know they have it yet. And then, of course, we do palpation to see cysts or see where the organs, if the liver's too down too far, which shows congestive failure, all of these things. So that is an abdominal assessment. Now, another part of an assessment is the heart and understanding where the valves open and the closing of the heart. Children are born with congenital heart defects, and we're going to learn this week 5. But we figure these out, and sometimes nurses find it before doctors by knowing where to look for things. The aortic valve, the second intercostal space, right side. Pulmonic, second intercostal space, left sternal border. The mitral valve is the 5th intercostal space, mid-clavicular, and then the tricuspid valve. Now, why do we need to know where these valves are? Because if there is a leakage or a clicking, that means it's not opening, closing right, and there could be backwards fluids, congestive failure, many things can occur. So finding it quickly, and again, can make an intervention by the physician, and maybe they need medicine, maybe they just need their weights monitored closely. So knowing the valves. Now, children are very unique and special in their breath sounds. I was telling my classes earlier today and yesterday, children have big adenoids, big tonsils, and they always have this mucus, it seems. And if you listen right over the trachea, you're listening to bronchial sounds, which is more like upper airway secretions. It's not really the breath sounds. This is children. Once we go and we do the bronchial breath sounds and we see that there's junk, then we're going to go and look at the other areas of the lung to see air movement. The bronchial vesiculars or the trach and the bronchi bifurcate. This is still more upper airway. Now, vesicular is the lung surfaces. This is your lobes where you can hear air coming in and out. Once we see the bronchial has this noise, this rhonchi looking secretions, and we hear it lower, but with air coming in and out, we know it's a referred sound. So we know lungs are clear, but we have upper airway secretions going on, okay? This adventitious sounds, that's that referred sound I talked about, upper airway versus the chest. So if we know it's up there, we listen, we hear air, we know that the lung sounds are clear. Now, safety in children, car seats and infant restraints. So we know that over time, infant restraints have changed like crazy. I know that my firstborn, who's now 38, he had a car seat and it was front facing. They didn't know to put it backwards. We didn't know there was expiration dates, and nobody was teaching us how to put these car seats in so that it could be safe for our children. This has evolved over time. And if you look at that seat up there on the top, I remember having that as a kid, this little bucket thing, almost like a milk crate that you sat in. So they have changed over time. Now, car seats do expire. So one thing about car seats, you shouldn't be taking a car seat from a garage sale that you don't know how old it is. It's something that won't be safe. We need to have car seats that, I mean, it could be from your friend's car that's only 2 months old. That's fine. You know, that's okay. Of course, a new seat's always great, but any car seat's been in an accident or, you know, you don't know expiration dates, you would never put them in your car for your child because you don't know if it's going to protect you very well. So there's a website here you can look a little bit more about there and more about safety if you'd like. Sexually transmitted infection and prevention. Well, you know, I have it here as a baby because we know if we don't protect sexually transmitted infections with a vaccine as a young adolescent, they could get to the point of having, you know, vaginal warts, and then the baby can be born with them. So it's important that we take care of our children. Now, HPV vaccine is the one that we give to a young girl. It is 2 injections 6 months apart, and this helps prevent cervical cancer. Hepatitis B is given at birth to infants, and we give it 1 to 2 months later and at 9 months, just to help prevent the opportunity for these children not to get hepatitis B, because hepatitis B is not a good and a disease to have. Infants. So there's a lot of stuff, a lot of growth and development with infants, and a lot of growth in different months with what? Knowing the forward advancement of fine motor and gross motor, it will help you understand that 1 year of life. So review your fine motor, review your gross motor. So 5-month-old, what would you expect? Well, this child still, you're going to have to, the head is coming up with when you pull the arms up, but still it's still weak. I mean, it's still not as strong as it should be. They're able to roll from front to back, not quite back to front yet. They like to be on their back and put their feet in their mouth, because remember, Freud says oral in the mouth. They cannot just do reflex, they're doing voluntary grasp with their hands, of course, everything oral. And maybe it might be a tooth coming up. So if you had this infant at 5 months old and they are not able to sit, you know, at all, or their head is completely lagged back and there's no, you know, help trying to hold it up, something's wrong. Again, early intervention needs to take place. So that is my recommendation for growth and development. Look at gross motor skills, look at fine. Remember, fine is all about fingers, grasping, pincer, palmar grasp. Okay, these things you need to know. And then the gross motor skills, that you lift your head up first, that you turn from back to front and front to back, and you up on your knees, and then you start creeping around and walking by 12 months. So this will help you keep in line with questions regarding growth and development. Colic is an extremely difficult thing to work with children. Now, if you were in a doctor's office and a mother called you up and says, you know, my child is just crying 15 hours a day and I don't know what's wrong, what you should tell them, because you can't know, is it colic or is it something else? They need to be coming in and being evaluated. A colic is a child, they say, that cries more than 3 hours a day, more than 3 days a week, more than 3 weeks. It usually stops about, you know, 3 to 4 months of age, and maybe up a little bit more than that. Colic is when they have gas, they're miserable, their abdomens are tense, their legs are just pushing, and they hurt. So again, and it doesn't matter if it's formula or if it's breastfed. So if you get a call about an infant that's crying more than that, never assume it's colic. There's other conditions. There's things like intussusception and even appendicitis for young kids. So it should be able to go in to be assessed. Don't assume it's just, oh, give the baby some gas drops. Don't do that. So what is the difference between sequential trends, developmental trends, and the sensitive period? Well, sequential trends is when there's a predictable sequence of event of growth and development. As in, we know that a child lifts his head up, he turns over, that he starts to crawl, creep before stand before walking, and this is all up to 1 year old. Again, this is your gross motor skills that I was talking about. Developmental pace is how your child learns different skills. It could be that, fine motor, that some children will go from, voluntary palmar and then able to do more of a fine, but it's just the pace of the child. Every child is different. But again, they usually will go from, creeping to walking. My children went from creeping to running. They never walked, but it was later on in age, but they're going in the right place. And the sensitive period is when time where the child learns to talk and to move and to get the things that they need. Okay. This is making them say, if I cry, somebody comes. It also says, oh, if I use my feet on my knees, I can crawl. So it's doing those things. So you have these soft spots in the head. You have the anterior and posterior fontanelle. And these are open at birth so that a child's brain can grow. Yes, their heads are big, but remember, they're growing, tripling their birth weight in the first year. So the posterior is going to close between 1 to 2 months and anterior 9 to 18 months. Why do we know that? Well, if it's still posterior is open at a year old, there's something going on. Why is it still open? Is the child's head big because of hydrocephalus, a brain tumor, whatever? So understanding these numbers will help you diagnose issues with children. So children have this binocularity, which means they have one eye that looks and the other one looks, but they're not looking together yet. I mean, if you and I put our finger out and point to something, you close one eye, you'll know which eye is more stronger than the other, but they're both looking the same way. Infants look in 2 different ways. So if you see this kids with the crossed eyes, that's what it's talking about. They should be working together, and it starts with both of them working separately, and then they come together. Now, why do we do that? That's how you can grasp, that's your depth perception. We know as the kid gets older, their depth perception becomes keener and keener. They're able to, with one hand, get it instead of trying a couple times to grab something. So pain and pain scales are important. We know infants' pain scales is the FLAC, and it has to do with their faces, with their legs moving, their activity, and their chin quivering and crying and the inability to console them. Many times you think crying is they're hungry. Well, if you pick them up, you try to feed them and they're not being comforted, they're in pain somewhere. And it could be colic, could be constipation, could be gas, could be many different things. So an infant who cries, that's unconsolable, this is a child who's definitely in pain. So kinds of things that increase the risk of sudden death, sudden infant death. Now, this is your SIDS death, and this has to do with the way that we position our children today. Years ago, everybody put their children on their tummies and let them sleep. And we have found that children will vomit a little bit. They have no movement of their head, and they were aspirating their own vomit. And then we said, let's put them on their side. They were inhaling the CO2 that came out, and they would die because of that. So today, it's back to sleep. And they do get the flat head in the back, and that's okay. The children are alive and doing well. So how do we, besides putting them on their back? They're going to have a harder bedding, not soft, no blankets, no bumper beds. Do not share your bed with the baby. I have seen an adult male roll over on his infant and smother the child and wake up and the child was not alive anymore. So it is real. It does happen. I've seen it. Also, If you are dressing a baby, you don't have to put them in 3 different onesies if you're there in a tank top and you're, just comfortable. You put one more thing on these children, they do well. Cigarette smoking, whether it's during pregnancy or in the house, can cause it. Little or no prenatal care, of course. And then if the kid's been sick recently, with mucus or cough or cold or ears or something, this is another big risk factor. Young children, of course, premature, are always a risk for SIDS, and males are more than females. And another thing is many mothers decide to breastfeed because their risks for SIDS deaths go way down. The formula-fed infant is more at risk to have a SIDS moment. So these are some of the infant's reflexes. There's a couple we'll talk about. One is moro. Moro is when all of a sudden let's say you hit the crib and the baby spews and the legs come out. It's a startle response. It's almost like a fight or flight. That's what moro means. Rooting is when you take and stroke the little cheek, and that's the baby's looking for the breast or food, okay? And of course, we know Palmer by reflex Palmer and for voluntary Palmer. And those are the big ones there that you need to know. I included some more in there, but those 3 are the ones you see all the time. Gross motor skills, here we go. It's a whole timeline for you. Holds the head up steadily about 2 months. Head and chest up on tummy time. So they're sitting there and their heads are going up. I mean, if an infant is back to sleep all the time and the back of their heads are all flat, if we do, when they're wide awake and alert, put them on their bellies, they'll sit and hold their head up and it will take some pressure off the head and it will round the scalp because the bones are soft still. So it's good, it works that way. From 3 to 4 months from tummy to back, they roll over. 6 to 7 months back to tummy. So we know at this age, by 5 months, if we have a child who's on a couch with nothing to support them, they can roll off and fall on their heads. Or if they're on the changing tables, they can roll off and they can really hurt themselves. So knowing the developmental stages knows how to protect children. By 8 months, they don't put in your book 6 months, but it's 8 months sits with no support. They can sit there. By 9 months, they can pull themselves up, they can crawl, they creep around, then they stand, and then they should be able to walk between 12 months. Now, if this infant isn't walking by 12 months, but still working in a frontwards progression of these, the baby's fine. I've told my students, my grandson and my kids never walked. At 15 months, they ran down the hall away from me. So as long as they're moving forward. Toddlers. Well, we know the head circumference is going to be equal to or less than the chest by this time. So you have a little 2-year-old and you need to go in there and listen to their lungs because they came in and they had a fever and a cough. So you need to listen and do an assessment. How are you going to walk into that room and how are you going to get the attention without this kid screaming and yelling or taking off down the hall and running away from you? Well, get on the floor, get on the chair, sit next to them and just don't immediately go after them. Maybe at this point, you tell them, you're cute or you know where your ears are. And many of these young children, toddlers, here's my ears and here's my nose. So you get them playing. Now they're comforted. They don't feel as threatened. Now you can listen to many things. You can also have them touch the stethoscope. You can have them put the stethoscope to their chest. And this will help you do an assessment without the kids screaming and yelling and kicking the whole way through. If a parent's holding a child, let the parent hold the child. That is their most comforting place that they have. So 2-year-old, what signs would you see if they were exhibiting pain? Well, number one, 2-year-olds are what pain scale? Well, they're 2. It's still the Flack scale, okay? So what do they show is when a child is in pain, these young little toddlers, all of a sudden they're going to be sitting. They're not going to be running around like normal. They're not going to be playing. They're not going to eat. And they just might be crying or just not looking good. When a toddler don't feel well, you will know their behavior is completely changed. So the best pain scale, we got a FLAC, okay? You do not go to FACES till preschool, ages 3 and 4. So according to the American Academy of Pediatrics, when should you introduce whole milk to a child? And the answer is 1 year old. So at 1 year old, you can introduce whole milk. And I was asked, why whole milk? Well, they need the fat, they need the calories at this point, unless this is a child who has a weight that's bigger or more than it should. But most of the time, 99%, you can introduce them to the milk. Remember, milk does not have iron. These formulas are iron fortified, and then breastfed parents do give supplemental vitamins. So remember that milk does not have iron, but these children can eat now. They can have green leafy vegetables and it's full of iron. So preschooler, how do preschooler children develop a sense of morality? Well, morality, Kohlberg, right? Moral, think of moral reasoning. This is Kohlberg, okay? So 2 years old, all of a sudden, they start, as toddlers, starting to understand right and wrong. They're starting to go, oh, I did that and it wasn't good, so I can't do that again. It doesn't mean they're not going to try again, but they're starting to understand. They also, if a child knows that they are going to be put on timeout when they do something wrong, most likely they are not going to do that wrong because they actually want to please parents, okay? Now, another thing, a little toddler, preschoolers at this point, when they see somebody they know and love and they hurt, they're going to go up and kiss that boo-boo or give them a hug. It's that sense of understanding, empathy. They're starting to think about others besides themselves. So preschoolers, what age is a child when they fear if they get hurt or get an injection that all their bloods and insides are going to leak out? It's what we call the age of Band-Aids, and keep many Band-Aids in the house. Young children believe in what we call mutilation, which means they get cut, everything's going to fall out, and they're going to die because they're going to bleed to death. So Band-Aids are the perfect thing to that. Pain scale to use for a preschooler. This is your FACES. They can point to the face and they'll point exactly where they hurt. And they might point at a 3 or they might point at 5, but you know that that is something that they really are, because children don't lie about pain. Children are that person. Could somebody mute? Okay. Children don't lie. Whatever pain they have is what they have. They don't exaggerate it. Adults do, but not children. So FACES is a great scale. And then, of course, we go to numeric, which is 0 to 10, and that starts about age 8. So can you name the gross motor skills expected for a child from preschool age? Remember, gross is hop, skipping, jumping. Remember, fine motors is fingers, what you can do with your hands, okay? Because you're going to have questions always that talk about gross motor, fine motor. Don't get confused with your answers. Sometimes, well, they both look right. Well, one's fine motor and one's gross motor. So knowing the difference, very important. So at age 3, they should walk on a line and they could go on a small balance beam and skip and gallop and walk backwards. And they can ride a bicycle. They can catch a ball and they can jump with 2 feet. By the time they're 4 or 5, they can stand on 1 foot. In fact, what they start doing is the other kids start standing on their feet and they start trying it too, and they can. They go on their tippy toes, they jump. They can jump up into a step, they can go over a hurdle, and they're much more coordinated. They can run, play ball, go forward, backward, sideways right away, and they don't lose their balance because now they're more coordinated. Fine motor skills, okay, preschooler. As you can see, there's pictures of things they do with their hands, whether it's coloring or cutting or buttoning up a shirt. These are fine motor. School age children. Now, getting ready for kindergarten is that age of a child's life where they're breaking away from their parents' home or even their daycare, something that they've known, into a different environment where they have to do certain tasks, they have to listen, and they have to be respectful of other children. So it is a big preparation. So how do we get our children ready to go to school? Well, first of all, we need, as parents, to say that learning is good. You know, reading books with a child at home is so important. If there is some sort of way for other organizations to help you teach this child, they should always be used. You know, some of the preschools are really good and they do help, you know, learning colors and learning letters and these things they can bring. Because remember, school age children, they've got to be able to sit now. They can't be running around like they do at home. And speaking to your children with full sentences and using those words, and they do really start understanding those bigger words when you start talking to them. School age. School age, according to Freud, is same-sex peer acceptance. Very important. They need to have a friend, a peer who is their friend, who accepts them. Very important that they accept them. It makes them feel a sense of security and being happy. Another thing with school age children, risk factors and health concerns of children with obesity. Well, what I've told you about nutrition, what I've told you about infants and monitoring weight and seeing where they are on the weight scales. Are they overweight at 6 months old? We could prevent some of this, but not all the time. Having a school age child who is overweight is getting to be an epidemic in this country. Many times it's due to sedentary playing iPads and games and phones and all those, and they're not up and running around well. Also, we need to be feeding these children well from, you know, intrautero and from infant well, but not that overfeed. Good food, good nutrition. These children need to be kept active. They need to be outside, running around, engaged in sports, whatever we can do to make them be in motion, not just sitting, doing these video games, etc. And there's something called an increased risk of cardiometabolic changes in obese children. That means when these obese children become adults, they have higher risk for hypertension, for diabetes, and hypercholesterolemia. So an obese child can lead to more problems. So let's take care of it right now. Let's teach these children on what and how to eat so that they don't get to that point and become those adults who are sick, you know, with these diabetes, hypertension. Now, it doesn't matter race, your financial status, nothing has to do with why a child would be obese. It has nothing to do with that. It's teaching them the how to eat so that they don't. The prevention is what we need. And hopefully that we can keep more children from not being obese. How do you prepare a school age child for procedures? Well, school age is from 6 to 12. It depends on the age, number one, right? So again, use language that they understand. I'm going to put a big camera in front of your chest. It's going to be big. It's going to make noise, but I can see right inside you, and I'm going to be able to see your heart and lungs. And I'm going to show you after the x-ray's done. I'm not afraid if I'm a 6-year-old now, am I? No. So speaking to children in that way, you're going to have a child who's more willing to go in, be happy, excited to get the x-ray, wants to see what that broken arm looks like. What is that broken bone, inside of my arm? And they get excited with it. Or you'll have 6-year-olds running the other direction down the hall because they're afraid. How do you assess the hypoglossal nerve in a child? Well, just stick their tongue out, and you could see even infants do it, and they do it easy. And this is cranial nerve number 9. It's one of the assessment things we do. So lymphoid tissues, how do they affect children as they go? Your lymph nodes. Well, we know that there's a lymphatic system in the body. It's part of the immune system, and it helps fight diseases and infections. And we know that as a child grows, gets immunizations, their system becomes stronger and stronger and stronger. Now, children, when they get these viruses and these, little upper respiratories, their body's making all of these antibodies. So now as they get older, they're going to be healthier. Now, what if a kid is sick and these lymph nodes are part of the lymphatic system? What would you see? Well, if they're sick, you're going to feel them. But if they're healthy, you shouldn't be able to feel a lymph node at all. Non-palpable. Dental health, important. I think one of the easiest things to say about these school-age children. Now, remember, school-age children start with baby teeth, and in the end of school age, they've got all their permanent teeth. So it's important that they keep their teeth clean. So how do we do that? Well, brush the teeth, especially before bed, so they don't sit with, sugar or something on their teeth, and flossing. Soft nylon bristles, nothing hard, okay? And then, of course, fluoridated toothpaste are recommended on children. And if we do all these things, this little school-age child should be an adolescent, an adult with beautiful white teeth. What causes the most death in teenagers between 15 and 19? Well, you can see some pictures here. We have violence, which is a homicide with guns. We, of course, have those motor vehicles because not only are they in the car, ran over by the car, now they're driving these things. They've got their driver's license, so that's part of it. And then, of course, we have suicide due to severe depression. Adolescents are those children going through so much mental turmoil. This is what Erickson is the time of identity. What's my identity? Who am I? What am I going to be? Do I like boys, girls? Am I a girl? Am I a boy? And just all this turmoil is going in the brain. And who's my peer group? Who do I want to hang with? What do I want to be? And adolescence, sense of identity, as I said. Erickson talks about sense of identity. Again, they're rebellious. They're trying to go out and do whatever they want. They're testing boundaries like crazy, and they're fighting for independence and control of their environment. Most of the time you see this independence and control about ages 15 to 17. It's that middle adolescence where they're like, not, those beginning freshmen. Now they're like sophomores and juniors, and I want to be able to do what I want to do. I'm doing good in school, and I'm going to test everything because I don't know who I am. I'm trying to go out there to find those things out, sometimes in the wrong ways, but they've got to be able to go out and seek with mommy and daddy waiting for them at home. Now, as a nurse, we're going to have to talk to adolescents, and they can be very difficult to talk with. Now, we know how to talk to the younger children. We sit down, we start talking about their shoes, or, freckles, their beautiful eyes, their Batman shirt. That's easy. Now, what do we do with an adolescent? Well, let's start talking about, so what did you do last weekend? Or, oh, I heard you listening to some music. Who do you like? Who's your favorite? And you build up, now broken the ice, you seem interested in the child. That's what they want to see, that you're interested in them. Because, right now, this age, this children, most of them, you have to come to the physicians, wherever it is, with mom or dad. So, now I'm just another adult. But when you start talking these social issues, you're going to break the ice. So when you're talking to an adolescent, of course, it's first mom and a child or dad and child, but then let's say you have to talk about some sexual activity or, what's going on there. You can tell the mother to leave or the father to leave and talk to that adolescent. And they're more willing to talk to the nurse than they are to the parents. I wouldn't talk to my parents, so I understand it completely. But they're going to tell you things. Now, you don't have to tell that mother or father what went on there unless it's activities that could cause harm to them or to others. And another thing is they're talking, just let them talk. They're going to sometimes say things that shock you. Don't let it shock you. Just keep shaking your head and go, oh my goodness, inside. But it's okay. They're talking, and that's what the adolescent needs to do. So confidentiality is the big thing, with your adolescents, and knowing that you don't have to tell the mother, it can really help. It really does help. And it does set that, gives all the information you need to make a good diagnosis and treatment. So again, making sure the adolescent has the ability to express themselves is important. Now, teenagers are sleepy. Why? Well, they go through a 20-25% growth spurt in pre-adolescence over the 2 or 3 years, which is a lot of height and weight that goes on. So they need good nutrition, they need sleep, but teenagers, they want to be social, they want to go out all the time, they want to hang at the park, go to the movies, go to the mall, whatever. Are they're home studying because school's important, they want to get the A's to get to college they want. So are they sleeping properly? No. Are they getting the proper nutrition they need? No. The reason is these children, adolescents, are into that body esteem. Body image is huge. And many children, especially the girls, think that they're overweight when they're not. So they won't eat as much as they should. So that's why your teenagers are sleepy. The groups that should sleep the most are infants and teenagers. And we know teenagers don't. So stages of puberty, it starts with the girls with breast buds, okay? Boys will start with your scrotal enlargement, and then it goes further. So this is some of the stages of puberty that I put in here for you. This is Tanner stages to review on how the changes of puberty start. So when you see breast buds starting, all right, we're going to go through puberty very shortly. There are 5 basic dosage calculation problems. If you saw me for dosage calc, I've given you your examples. You have them. You should do well. You've got Betty, Professor Bogart's Pediatric Nursing YouTube channel, and I highly suggest, if you don't know dosage calc, it's there. And the worksheets should be from your professors. If you didn't get it, just holler to me because I have access to all of you. I can give it to you. So any questions? Okay, feel a little bit better, more confident, know how to approach this stuff now? That's all I want for you.
Yes, thank
ma'am.
you.
Yes, thank you. Thank you so
Great
much.
evening,
you.
guys. You're
Yes,
very
ma'am. Thank you. I
welcome.
hope you feel better.
I thank you so much. Time for
Thank you.
Tylenol. Bye.
Thank you. Bye.
You're very